So the comment was about stigma and having to really think about that methodically in the approach to screening, especially as we not only screen and go to the assessment, but how we transition care. If you're not going to handle it, how do we refer it? And it even trickles down to how does the person at the front desk look at them the next time they come in? You roll your eyes, big sigh, condescending on the phone. You're hurting your baby. That's just awful, right? So what percentage of the patients that I saw, and I saw over 380 pregnant patients on a controlled substance, what percentage of those do you think had been sexually assaulted in the previous 5 years? 96.6%. How many of those had severe on the trauma scale? On the ACEs, the Adverse Childhood Event Scale. So when we would screen for that, what percentage of them met for severe? 100%. So we stopped screening. It was a wasted tool. I mean, we had other things we needed to check for, and it was 100%. And so when we build a system for perinatal, you have to build a system that understands that they're not going to trust immediately somebody who looks like me. They're not going to necessarily trust a male doctor or male nurse. They're not going to necessarily trust that side. We had a lot of relationship building that took place in my clinic because I felt like we had the ability to show them that honestly, all males aren't horrible. You know, that you can create a perfectly appropriate relationship with someone who has your well-being in mind and can do that, for them to be able to see that for that. But I have to say some aren't ready for that. And so figuring out how you're going to make sure and structure a clinic that those that are really not ready to even think about that or look at that I'm not triggering that PTSD every time that they come in and see me, no matter how nice or empathetic that I am. And so thinking about that in an OB-GYN office about who's doing the pelvic exam. You know, how are you doing it? Because let's say we back up a little bit and recognize that not the entire world is not heterosexual. And we start to look at where did that trauma come from. Because if they fit into the LGBTQ plus community, the female may cause the same thing. And so just being really sensitive to these things without bringing on our own emotional baggage becomes really important. And so building a trauma-informed system means that my social workers are obviously trained. They're the most trauma-informed people in the office generally. But all the doctors are really trained in trauma-informed care and monitored for that. Meaning that they get pushback when they don't do it. When they're like, yeah, you know, some of that stuff comes through the breast milk, so you can just pump and dump and you should be fine. That's all accurate. Kind of a total, you know, say it, I never know which crowd I can drop, you know, words like douchebag in, but that's pretty bad, right? You know? But those are things that are not very trauma-informed care, but I think you have to be methodical, and there is science behind it. It's not a guess on what trauma-informed means. It's not just being nice. It really is about reframing the entire interaction with the person and understanding that this is all about them at this point and what support I can bring and what information I can give, and not about what I'm telling them that they need to do. And it really does do that. So that's a great comment. And we spent a lot of time, I think, yesterday on trauma. And you should just understand that when we're talking about addiction, it is a traumatic disease. People do things they never thought they would do. They have guilt and they have shame. And in this population, the guilt and shame is unparalleled. And yet what we do, generally speaking, is we continue to re-shame them. That whole you're hurting your baby thing just drives me insane. I literally... It's difficult to not have a pretty overt reaction when I hear those things. I do, however, correct people. So when I work, I still work clinically. I work in the emergency department. I actively and professionally correct people's language. Because that's a part of what this is. If we hear somebody who works with us in the same clinic say the wrong thing in the wrong way, you know, junkie, dirtbag, you know, dirty urine, these are things that you just correct. And I say it in a very trauma-informed way to them. Because a lot of, you don't really know what your colleagues have gone through, to be honest. And I'll talk a little bit about what I think about stigma for addiction, but for this population, it is really easy for us to shame them and beat them up. So we have to hold each other accountable. we have to pull them aside and say, look, that language made me really uncomfortable, and you may not even realize it's there, and I'm sorry to even bother you about it, but I have to just say, when you said that, it made me uncomfortable, so I can only imagine it did that for the patient. So you can take that or leave it, but I kind of had to say something. And walk away. You don't have to be, all hyperbolic about it. You don't have to write a complaint. You just can have a conversation. But I think it's really important to hold each other accountable. Because what I found out is that my staff, when I started to talk to them and train them about how to do this with people, and when we started to train each other and keep each other in line, I recognized that a good chunk of my staff had pretty significant early life trauma themselves. I'm not treating them in my office for anything, but they were also sexually assaulted, or they also had a significantly violent childhood growing up, or they were neglected. So there are a lot of things, the baggage that we all bring in some capacity to what we do, and it's really important to recognize that training people in this may also mean a little bit of therapizing of our people around us as we go. Because not only if you've had this in the past and we're seeing this and you work in this field, the field is traumatizing. If you're not aware of what you're seeing, that's secondary trauma of rolling into pregnant addicted patient, hearing all of their stories of assault and neglect and just all of this stuff. I mean, it can be a little overwhelming over time. So making sure we check in with each other and make sure we're all on the same page for that. So let's say we've done that. Let's say we've screened. Let's say we've done an assessment. We identify that they have an opioid use disorder. And they say, well, what do I do? What do we tell them? What does the evidence show? So the evidence shows that if I put them on a medication, whether that be methadone or buprenorphine, that it decreases their chances of miscarriage. It increases their chances of full-term delivery at correct weight. Head circumference is normal as compared to that. It's the same, it's not below anything, so it increases the chances of that being normal. Decreases chances of HIV, decreases chances of hepatitis C, decreases chances of incarceration, actually decreases chances of sexual assault because they're in less risky situations trying to obtain or use the drugs, decreases chances for domestic violence because we're more likely to get their partner into treatment. I don't know of any other treatment that kind of does all that stuff. That's a lot of stuff just by adding it. Being on a consistent opioid without contaminants throughout pregnancy causes no short or long-term harm that we can identify for the fetus. Let me repeat that. Being on a consistent dose of a non-contaminated opioid throughout pregnancy causes no short or long-term negative outcomes that we can identify for either the fetus or the newborn child. As far as hitting growth metrics, feeding, education, mental health disorders, none of those are identified in this population of kids. The utilization of drugs like oxycodone or heroin or other opioids in a fashion where you have intoxication and withdrawal cycles, that can cause, one, it can increase the chance of having a preterm delivery or miscarriage. It can also increase the chances of having behavioral conundrum that happen later in life. And that, generally speaking, is a mood disorder in the early preteen starting that they can identify. And so stabilizing a mom on medication-assisted treatment also decreases the risk of overdose, 60% in a year. Actually, for pregnant patients, it's less, 40%, because overall, females generally will decrease use during pregnancy. They generally won't stop, though. That's the thing, is it doesn't stop. But if it's alcohol, we see a huge decrease in use. Tobacco, we see a huge decrease in use. Opioids, if they're injecting heroin, we kind of don't see it because there's only so low you can go without going into withdrawal. Right? And that's what they're having to walk through. So there's some reality things. Is they're motivated many times to do it, but if we don't ask them, they're scared, they're shamed, they're frustrated, they're worried that if they tell somebody, you're going to take their baby away. Right? And I think we've done a really poor job of supporting our child protective services in this setting as far as by education and by professional liaising and being able to interact in a way that we can take someone who delivers what is one of the most complex and frustrating jobs that I can imagine. So my mother-in-law is a child protective services worker in Detroit. And so she's busy. And it's And I've gone out with her a number of times because I'm writing a curriculum for Child Protective Services in Michigan right now for training in addiction, and I can't really write it if you don't know what they do. So I've been out in the homes, and I've been a paramedic and worked with police, so I've been in these situations before, but it's very different when you have to make the decision based on the report you write of whether or not you're going to literally take somebody's kid away. This is really complex stuff because the report that's written and delivered to the judge generally is followed. So when we look at the data to find out what should we be doing, what is the best thing for baby? You know, when we start to look at short-term and long-term in that. So if you have a mother who's unwilling to get treatment, has a severe addiction, baby needs to come out until we can get that mother stable and get them in the right place. If a mother is in treatment and on medication-assisted treatment and showing up, then she should deliver her kid, she should be breastfeeding, and the baby should go home with them unless there's obvious other extenuating issues that come out. But just the fact that they have addiction is not a reason to take baby. What we found is that if you do that, you actually at that point start the domino effect of an attachment disorder that will affect this kid for the remainder of their life and actually decrease their chances of graduating from high school, decrease their chances of being stable and having no addiction later in life. We don't increase it by keeping it with mom, interestingly. That genetic railroad track has been laid. So that's there. What we have to do is identify that the most important thing that we can do in early post-delivery and early childhood is create a bond. Because that bonding capability is what allows us to connect with the remainder of the people around us throughout our lives. And if we don't learn that early, we lose that capacity because the brain, when born, is built to purely be a dopamine, oxytocin, serotonin factory. It is their pure survival emotions. That part that I said, that reward system, that's all that's working in them at that point. And they get reward from feeding and love. That's it. Those are their two pathways for reward. And I gotta say, formula tastes like crap, so I'm pretty sure that if we're just feeding them formula, they're not getting a huge dopamine bump from that. It's just satiating the hunger. But what they do get a huge bump in is oxytocin and dopamine after birth with having a mother-baby bond and breastfeeding and having skin to skin and being connected. These are the things that we know, and we can follow that, and we can see that when you swaddle them or hold them, if you're looking at them for neonatal abstinence syndrome, you basically cut the score in half if you just hold them. So these are really basic things that we don't think about, but are really important. So the other piece is, this is another one that makes me mad. This one makes me the maddest. Well, we don't want those babies born addicted. If you say that and I hear you, I will punch you in the throat. I just want you to know I've hit a point in my life and career where that one's just not okay for me. I'm just gonna go Texan on you. It's gonna be old school, and I'm gonna have trouble, and the guys in the back over there have to come talk to me with metal handcuffs and stuff like that. But that thing drives me insane. And it drives me insane because how do we define addiction? We define addiction based on a set of behaviors associated with obtaining or using a drug. And I do not see a lot of newborns strolling the street looking for their next person who's going to sell them a dime bag. I do not see that. What I see is someone who has a physical dependence to a substance. A physical dependence that has to go through withdrawal. Once the withdrawal is done, it's done. They don't have addiction, they have a physical dependence to a substance that abates after about 72 hours. What else do we deliver babies physically dependent on a regular basis and do nothing about? Tobacco, like nicotine, that actually has a mortality rate associated with its withdrawal. You have almost a 30% increase in SIDS for people who were born on using nicotine throughout their pregnancy, whether it's vaped or smoked. What about SSRIs? So we give people SSRIs because it decreases their chances of having a psychotic episode actually during pregnancy. If they have a mental health disorder, it increases their chances of following up and doing all of the things that we want. And it also just makes them function, right? It keeps them from being super sad and isolating. It keeps them from being anxious, depending on which one we're treating. But there's a pretty significant withdrawal syndrome to the neonate after they deliver from an SSRI. So we already do this on a pretty regular basis. We just haven't labeled it as such and haven't put pictures of babies in withdrawal, which, by the way, has anybody seen like videos of the babies that are in acute withdrawal? I want to pull out some Texas on that NICU doc for not treating it. Just treat it. I mean, why in the world am I taking a picture of a kid in withdrawal when I can 100% treat withdrawal? It takes me less than about 3 seconds to treat withdrawal in a neonate or an adult. And to have somebody actively withdraw for no reason when we have the capacity to turn that switch off is crazy for me. So when we look at this, if a patient does, if a mom delivers, and then she breastfeeds and they swaddle, with buprenorphine, about 70% of those kids go home with mom. Very few of them even need to be in the NICU at all. And the 30% that do, most of them are out of there within 3 to 5 days if you use the basic methodology of eat, sleep, and console. But what we do, we've built these algorithms that if you see NAS, neonatal abstinence syndrome, or pediatric withdrawal, then we start a pathway where we're going to give them this medicine and we're going to wean them over 2 weeks. So we mandate them to 2 weeks of meds when it's only a 3-day syndrome. This is a very interesting thing that's occurred. It's unoccurring at this point. We're backtracking on this because the average length of stay for neonatal abstinence syndrome has been around 17 to 18 days. But with the newer, actually easier methodology where we keep mom close to baby, we make sure that we have breastfeeding and skin to skin, and we have all of these positive things. We go from 17 days to 4 days. So going from 21 to 7 was this huge Vaughan network thing across the nation where they did this big process improvement event and they decreased it by 3 days. This version that was originally done at Yale but now has been done in a number of other places where it's basic. Mommy's got to be with baby, you make sure that they're eating, you make sure that they're sleeping, and you console them when they need to be consoled. Eat, sleep, and console. Super simple. Right? Even an ER doctor can do that. It's really basic stuff. 4 days. So we're getting to the point where we're recognizing that the ability to deliver a kid at term, keep a mother stable within her disease and no longer meet criteria for active addiction and meet criteria for being in remission is something that we can easily do by using medications like buprenorphine or methadone. The fact that the baby has a withdrawal syndrome after the fact doesn't really matter in the long term. This always brings up the term that I have people that bring it up. Well, the baby suffers. Suffering is a construct that we emotionally give ourselves as an adult. It's not something that you feel at the beginning. Will they have pain with withdrawal? Yeah, they'll have a little bit of pain with that because withdrawal hurts. Anybody who's been in withdrawal in this room understands that withdrawal hurts. But the suffering is a construct that we put upon ourselves that a neonate is not capable of. We are suffering when we see it, which is an appropriate human response, right? But at the same time, let's not put our emotions, let's not, transfer our emotions onto that neonate, because they have a withdrawal syndrome that we can treat, and the best thing that we can do for them is give them a mom and a family. We had a birth plan, meaning here's how you treat the pain. If they're on this dose or that dose of this medication or that medication, here's the expectation for withdrawal for the neonate, because the mom has nicotine and SSRI and buprenorphine, and so when you add those up, it may seem a little more severe and a little longer, but be aware that it's still not dangerous, and breastfeeding is indicated, yes. Plus minus, is the mom been trained in breastfeeding? So we had this weird thing. I don't know if this occurs elsewhere. My assumption is yes, I'm sure it does somewhere. But we had the people who would come in and teach you about breastfeeding, and they would refuse to actually teach my moms about breastfeeding. Right? That's weird, because they're like, well, they shouldn't be breastfeeding, put those drugs in those babies. But what we recognize is that you get a significant weaning process when you breastfeed after these, and ACOG and American College of Pediatrics, everybody says you should do this. So the emotional context gets in there, but you also decrease the chances of neonatal abstinence syndrome when you get baby home faster if you breastfeed. And so when they wouldn't do that, I did what I normally do. I was like, fine, I'll do it. And so I went and took all these classes. So I was like talking about cross cradle and football, and then no, here's how you do latch. And so as soon as I started showing up after work in the evenings to do basically breastfeeding training for our moms in the clinic, then they're like, no, we'll do that. And then we fixed the problem. But at the end, it's just one of those things that we have to address it. So any lactation consultant in that situation needs to be on board with this, because they can also put that little bug in the ear of the mom, and all it takes is one negative comment to undo 100 positive comments. really important to understand that that little bitty piece of doubt from anybody, any chink in that armor can completely wreck what is supposed to be one of the happiest days that you have. And we want to make it that way because the happier we make it, the more likely we are to boost what? Dopamine. This is one of those rare times that we have that we can crank up natural productions of dopamine, and it's augmented by another one. What's the other thing that gets produced when you're breastfeeding? Oxytocin, which basically does the same thing as dopamine. It's like the backup system. So this oxytocin is great because baby and mom get some of this oxytocin boost, so it can really help to stabilize mom during this time and help them to be really motivated to make that mother-baby connection. But if we artificially separate them and say, you stay here, baby's under the warmer, over here, laying there with hands out, not really getting, what they need, that's not good for anybody. Mommy's not getting dopamine, not getting oxytocin, baby's not getting a good weaning protocol and not creating a mother-baby bond. They have to come together, So as we walk through, as we look at this, the biggest things that we have to think about when we're looking at the pregnant population is trauma-informed from the get-go, because the chances of somebody having a significant early sexual trauma, violent trauma, neglect, it's basically ubiquitous. The chances that someone within their care continuum is going to be a mean person is totally predictable unless we make a concerted effort to hold each other accountable. But the big piece is we have to just get over this very weird hurdle of using medication during pregnancy to stabilize mom for her addiction so that we can get a baby born to term and that we can birth a baby, walk them through any withdrawal management that they need, and then go home as a family. What is the highest risk of overdose for moms who have a substance use disorder between kind of pregnancy and a couple of years out? Where does that look? It's about 9 months after delivery. So we got to follow through on this, which means that we've done a good job here. We screened, we assessed, level of care, blah, blah, blah. Let's say we had the perfect clinic, perinatal, yada, yada, yada. Everybody's doing it. They're still on meds. But then we're like, all right, bun's out of the oven. High five. Can't be done. If you have a kid, you recognize that kids are pretty freaking stressful. Now think about someone who's still dealing with a chronic illness that they're having to deal with. If this person had cancer, they would have everybody on the block making food for them for months and offering to watch the kid and watching do these things. But they don't, right? They hide, a little bit of shame, a little bit of freaking out because some people don't understand and they're like, you're taking what with your baby? I mean, they still do that. We can't control the full environment yet. I think we can get to the point where we can educate enough so that we can take away community-based trauma, which still occurs. But at the same time, they start to isolate a little more. They maybe don't show back up to a next follow-up appointment. They're not really, we do a good job now of assessing for postpartum depression, but we have to really make sure that everybody's still assessing for postpartum stability within the addiction. And we only do that by communicating. But the only way that the patient's going to feel comfortable communicating, or me as an addiction treatment provider is going to feel comfortable communicating, is if I know you're going to be appropriate. If I know you're going to really do a good job with this patient. I know you want to. And even the people that say the meanest things have the best intentions. Nobody wants to actually cause trauma. Nobody wants to actually create a bad outcome. They just don't recognize that the actions that they're taking do. And so the goal is for us is to help educate each other that that action is the equivalent of giving the wrong medication. And you saying that actually increases their mortality rate. Let me say that again. There have been studies that have tracked if you have a single negative encounter in the pathway of your perinatal time frame, your risk of mortality goes up. Words matter. They are actually more important than sticks and stones in this setting. So we have to be really understanding of that trauma-informed, what has happened to you, not what are you doing, here. This whole piece of recognizing that they probably had a bumpy path to get here. Our job is to make it smoother. Our job is to be accepting and have their back the whole time. So follow-up afterwards is important. Making sure that you connect them with other moms who have been through this pathway is important. All of those things start to really create what is a habitat for growth in this setting, where you have people in recovery who deliver totally healthy kids who you would never know that they have a mom who's in recovery, because they're just like every other kid. They go to school, they poop themselves and scream and yell and do whatever that they're going to do. And then we just make sure that the pediatricians feel comfortable taking these kids and recognizing what they need to look for is not just with mom, but also, not just with the kid, but also a little bit with mom. How do we do a little bit more of a touch base, maybe a sooner follow-up after discharge, little things like that that can make a difference in the pathway of care. But those are the big pieces that we have to think about. There's generally a lot of questions that come after this, so I want to make sure that we have time for that, which is why we're going to wait until after the break, because I want you to stew on it. I want you to talk to each other a little bit, and I want you to think about what are the pieces that maybe are new for you, don't feel right, go against maybe what other people have said. Maybe you've read a piece of literature that doesn't comport with the things that I've said, and you're curious how they integrate. I'm happy to answer to all of those questions. If you don't feel comfortable asking that in a crowd, feel 100% okay just pulling me aside today, or they'll have my contact info and send me the question. I recognize not everybody feels great in a crowd, but the only way that everybody learns is if we all ask some of these questions. So I would please ask, if you don't feel comfortable, maybe we can even set it up so that people can write down questions. Great, let's do that, because these are very sensitive topics, and some people in here have been through this whole process and maybe came out really well, and maybe they're really invested in the pathway that got them well, and that's great. But we have to make sure that we're building a system for a population of people, not an individual who happen to get well in a certain pathway. And so I want to make sure that we work through all of those things, but if you feel uncomfortable having that be in an outward space, please feel free to write the questions, and we'll make sure to answer those for everybody so that we can all gain from that question or insight that you have.